Okay, so we're going to talk now about different forces that oppose lung expansion. So, if you're thinking about breathing in and your lungs opening up, and we talked about different muscles and movements that allow your lungs to open up, these are going to be the things that essentially oppose that make it a little bit more difficult. So there's two big categories that I would love for you guys to put on a flashcard. We have elastic forces and frictional forces. Elastic forces are made up of tissues, so your lungs themselves have a certain amount of recoil that's built in, right? You can kind of think about it as like a rubber band that as you stretch it out, it wants to recoil back to its original position. Your lungs have that same kind of tissue comprising them. So they're going to stretch out and open up, but they're going to want to recoil back down to their resting position. So that is an elastic force that is opposing inflation. Your thorax and abdomen are also considered elastic forces. Um, that happens in a couple ways. The tissues, as they're kind of getting stretched out, they have a certain level of resistance or recoil. The other thing that also contributes to recoil is just weight. So, if you can envision a patient who is, let's say, 8 months pregnant, laying back flat, and think about how the weight of her abdomen would make it much more difficult for her lungs to inflate and to open. So that would be considered like an elastic force, that pressure kind of coming down on her lungs, making it more difficult for them to open all the way. So those are your tissues that kind of comprise your elastic forces. The other elastic force that you guys are going to learn a lot about is surface tension. And so, we looked at the alveolar air sacs when we were kind of going through the different structures. And one thing that's important to realize about your lungs and specifically about those alveolar sacs is that we have like serous fluid, or you can think about it almost as like watery fluid that's in our lungs. And that has a certain level of surface tension. And all surface tension is when molecules want to join together. They want to be closely bonded, and that pulls a surface closer and closer together. And so, when you have that in your lungs, it makes the alveoli almost want to close in on themselves, and that's not something that you want. You don't want your alveoli to be collapsing. So, there's ways that the lungs deal with this surface tension to try to keep it in balance so that your lungs can open up. But that's another elastic force that we're going to be talking about. Moving over to the other category, to frictional forces, most of what we're going to be talking about with frictional force is airway resistance. Okay, so we looked at the different bronchi and kind of like the pathways through the lungs. We go from like the trachea to the mainstem bronchus to the lobar bronchus to the segmental bronchus, and they get smaller and smaller as we move through. All of those have a certain level of resistance. And if you start adding in mucus plugs or bronchospasm or airway inflammation, that airway resistance is going to increase. And that's going to oppose lung inflation. It's going to make it harder for your lungs to open up if these pathways are getting narrowed for a variety of reasons. The other part of frictional forces that's much, much smaller is tissue movement. So that's just the way that tissues rub against one another that make it more difficult for your lungs to open. That kind of circles back to when we talked about the pleura, the parietal pleura, which lines that thoracic cavity, the visceral pleura, which lines the lungs and that interpleural space, and how that's designed to kind of reduce those frictional forces because it lubricates the motion of the lungs inflating and recoiling back down, and creates more of a gliding motion so that hopefully it's not resisting that movement too much or creating an injury on the lungs delicate tissue. So just circling back, that tissue movement is another frictional force that we are talking about here. So for elastic forces, they can be applied in dynamic and static conditions. And all that means is dynamic is the air is moving. So if you want to envision actively taking a breath in, that entire breath, the air is moving. And then at the top of that breath, if you held your breath, so big breath in, you can tell that air is moving, it's filling your lungs, it's filling your lungs. Your lungs are completely full. And at the very top, when they're completely full, if you held your breath, that would be considered static conditions. The air is stationary, it's not moving, your lungs are inflated. So, elastic forces affect both the dynamic aspects when air is moving and static. So, even when you're holding your breath and you're holding volume in your lungs, there's still going to be elastic forces that are essentially trying to recoil your lungs back down into their original resting position. Um, Again, sources of elastic force or the recoil of the lung and chest wall are going to be surface tension, bony deformities, which is just your skeletal system, and then the weight of the abdomen. We are also going to be talking about lung compliance. So, in the same way that I have mentioned recoil, the lung kind of wanting to snap back into its original position, you also have something called lung compliance, which is how much your lung stretches. You can write on a flashcard, lung compliance equals stretch. Lung compliance you can have a high compliance lung, which means that the lung stretches very, very easily. You could have a very low compliance lung, which means it's very stiff and it doesn't open properly and it's not inflating like it should. Or you can have normal lung compliance, which should be a healthy lung that inflates normally and to the level that it's supposed to. So this is an example of a volume pressure curve. So this shows pressure being applied and then the volume that is going to be changing via different pressures. And this shows normal lung compliance. This would be increased lung compliance and decreased lung compliance. And so the way that you can read this is for every unit of pressure, you get a particular volume change, right? So you apply 1 unit of pressure, you get a certain amount of volume. 2 units of pressure, you get a certain volume. If you have decreased compliance, that just means that your lung is not stretching like it should. It's not inflating like it should. And there's a lot of reasons that this can happen, but that means that you're going to have to apply more and more and more pressure to get those lungs to open up to a normal volume, right? And you never want to be applying more and more pressure to something because you can create an injury there. And then conversely, if you look at the increased compliance or the lung that has more stretch than normal, for each unit of pressure, you're seeing a way larger volume change. So these lungs are inflating very, very easily with very minimal pressure. And the problem with that is in the same way that you can think about like stretched out elastic or a stretched out rubber band, you're not going to have the proper recoil back down for that lung. And we get concerned about that because, in the same way that we want to be able to bring air in easily, which would be affected with this decreased compliance because that lung would not be opening, you also want to get air out easily. And that would be a problem if you had too much stretch and that lung wasn't able to recoil down quickly and appropriately. So, these are some of the things that we're going to be talking about. So, for lung movement, you have elastance, which equals recoil, and compliance, which equals stretch. So, your compliance is the stretch, the opening up of your lung. The elastance is that recoil, that lung coming back down into its original position. This is going to be the stretch is going to be more for the inhalation side, bringing air in, and this is going to be for exhalation, getting air back out. There's a lot of factors that affect both of these, a lot of disease processes that will affect the compliance and elastance of lungs. And so, for us as respiratory therapists, as we start to learn the different disease processes that affect the patient population that we see and the therapies that we're going to use to treat it, these concepts become more and more important for us to understand. Okay, circling back to surface tension, the true definition or like the technical definition is the tendency of liquid to minimize a surface area by contracting. And this happens because the intramolecular attraction of the liquid makes it want to stick together. So, in a nutshell, these different liquid molecules that are in your lung, because you have this serous fluid in your lung, is wanting to stick together, right? The molecules want to bind together very, very closely. They're attracted to one another. And when they do that, they take the surface of your lung with them. So if you have your tiny little alveolar sacs and they're lined with this serous fluid, and these molecules of this fluid really want to hang out close together, they're going to bring that alveolar tissue with them and they're going to want to collapse it down. Okay, so this would be associated with like the recoil of the lung. This is going to be part of those elastic forces that we talked about. So you have a natural surface tension that happens in your lungs because of that fluid wanting to join together closely. Your lungs combat that with something called surfactant. Okay, we talked about how you would want to memorize the type 2 pneumocytes and how they create surfactant. Pulmonary surfactant basically becomes the awkward third wheel on a date, right? So if you're thinking about how you have these molecules that really, really, really want to get close, surfactant has these very weak forces that interrupt that. So they get in between those two molecules and they break them up. All right. And they keep them from joining together. So that will help to eliminate the surface tension that's going on in these alveolar sacs. And the reason that you want that is when you think about all of your gas exchange happening in these tiny alveolar sacs, you want to make sure that they're not collapsing down because you would be eliminating surface area for gas exchange. If you have a collapsed alveoli, that's not going to be able to bring oxygen into the bloodstream and remove CO2. So your lungs have this surfactant, it breaks up those intermolecular bonds, it decreases surface tension, helps to keep those alveoli open, helps to keep gas exchange happening. So this video kind of shows the way a surfactant works because water is a great example of surface tension. So if the definition and like the explanation aren't really landing, definitely watch the video. I feel like it kind of shows you exactly what I'm talking about with breaking up those molecular bonds. The reason that we really do need to make sure that surface tension isn't getting to be too much or that alveoli are not collapsing is because of Laplace's law. Now, I'm not going to ever make you guys memorize the mathematic components of these different laws that you are going to be reading about in Egan and then seeing in PowerPoints. I do, however, want you to understand the concept of Laplace's law. And so when you guys watch this video, you're going to see a gentleman, we'll just watch the video. I feel like that'll be easier. Normally I don't watch the videos with these recordings, but I feel like for this one, we can kind of talk through it.
I've got an interesting little demonstration here, and I'm not sure where you might put this in the curriculum. One thing is certainly with gases, it involves balloons, but it's just a good little eye-opener, and it's a good way of showing how math really has some power in the making predictions. So I have two balloons, and if you're wondering, this setup can be done with rubber stoppers and tubing and clamp, but this is a little different. This is the top of a little sport drink soda bottle. One of these balloons up big and the other one small.
But essentially what he's trying to show
and so to tell you that this thing has not been rigged, I'm going to actually use a coin toss. When it comes up heads, I'll make the orange one big. So heads is orange, tails will be the pink one. Okay, so here's the coin toss.
Is that each one of these balloons,
and it came up tails. Tails was pink, so the pink one's going to be blown up large. Okay, so we'll start by doing this. I'm going to blow this one up small, and that I have to open it like this. I'll put one breath, and we'll say one breath is about a liter, give or take. So
I'm going to let him do this, and then we'll kind of...
And look at how I can just push that back against there, and it holds it there. Now how do I blow up this one? Same idea. This one's going to be large. I'll put 3 breaths in here, 3 liters. Ready? Okay? Now, here's my question. What's going to happen when I open the passageway between these two balloons? Okay, I have to pop this open and pop that open. And when I first saw this done, I had kind of an obvious prediction. It's only fair that the balloon should even out, right? This is unfair. Well, let's see if that's true. So we're going to open this side, and now we're going to open this side. The rich get richer. Not at all fair, and not at all predictable. Or is it? Let's look at the situation this way.
Okay, so he's going to start talking about the math behind why that happened. Okay, so if you're looking at, you have a smaller balloon that is attached to a larger balloon, and if you open them up, you would expect that volume to equalize or that pressure to equalize, and that you should end up with um, balloons of equal size. And what ends up actually happening is that all the air goes to the already larger inflated balloon. The same thing happens with our alveoli. Okay, so if you have a collapsed alveoli, and it can be collapsed for a lot of different reasons, it can be collapsed because of lung injury, it can be collapsed because you have a surfactant deficient lung. There's a lot of reasons that alveoli can collapse. If you have a collapsed alveoli and then you have a normally inflated alveoli, air is going to keep going to the inflated alveoli and keep avoiding the collapsed alveoli. And the reason why is when it collapses down, that surface tension increases because it's smaller and smaller, and those molecules have been able to bind together more and more. And so that surface tension is increased. And just in general, it's going to take much more pressure to open that alveoli back up. So, Laplace's law is very, very important when it comes to thinking about lung injury and then the treatment that we're applying to a patient. If you have a patient that has a partially collapsed lung and you're trying to reinflate that lung, what you have to realize is as you're applying air or pressure to that patient, it's going to want to keep going to the part of the lungs that are already open. And you don't want to overly distend the alveoli that are already open, and you don't want to continue to not get air into the alveoli that are collapsed. So through positioning and all kinds of kind of specific therapies, we have figured out ways to reopen collapsed alveoli. So what you need to take away from Laplace's law is essentially the rich get richer. Air is going to want to move to the already inflated alveoli because it's like the path of least resistance. It takes less pressure to go that way. It takes much, much more pressure to open up a collapsed alveoli because of those elastic forces that we talked about. This is kind of showing that example of like not having the surfactant to break it down and what it looks like when it's collapsed versus an inflated alveoli. Um, okay, so on this chart, I got a little click happy. Sorry about that. Hold on here. Okay. On this chart, what this is showing is a normal alveoli. And again, this is going to be a volume pressure curve. So on the x-axis here, you have pressure. On the y-axis here, you have volume, right? So if you look at this red line being a normal alveoli, it's saying that you have to take this much pressure before that alveoli opens up and gets this level of volume, right? So this is your critical opening pressure, and that's a normal alveoli, right? This green line is showing you an alveoli without surfactant. So if you have a surfactant deficient lung, right, which can happen for a variety of reasons, but it's something that we commonly see in premature infants. So babies that are born early have not started producing surfactant, so their lungs don't have this critical component to them. And so if you look, the critical opening pressure for that alveoli is way, way higher, right? It's taking significantly more pressure to open that alveoli because that surface tension is so much higher. And whenever you're starting to apply high, high pressure to the lungs, you are going to be at risk of injuring the lungs. You can create a pneumothorax, which is a hole in the lung. You can create shearing injuries where the tissues are essentially popping open and then coming down, and that repetitive motion, because it's not smooth and because it's under a lot of pressure, can cause scarring to the lung, which can create all kinds of problems as well. Bottom line, you don't want to be having to apply high pressures to open the lung on inspiration. So surfactant is crucial. This video, which I highly, highly recommend you guys watch, talks about Laplace's law. It talks about surfactant deficiency in premature infants and how before we figured out how to replace or mimic surfactant, we had a lot of premature neonates that didn't survive because their lungs were being damaged so much by these high pressures that it was taking to ventilate them. So again, even though we move through like this material and it can get a little bit dry sometimes because of the math or because of it being really anatomy heavy, memorization heavy, just know that when you guys build this foundation, it's eventually going to link in to very cool treatments and very cool components of our jobs that truly do save people's lives and really help with their quality of life. So all of this has a place, and I promise you're going to start to be able to connect those dots later on. And it's really kind of exciting when you do. And it's definitely exciting when the knowledge that you guys gain, when you can see it helping people, when you can see it helping people in the clinical situation. Okay, so circling back, compliance equals stretch, elastance equals recoil. Think about compliance and stretch as kind of the inhalation side of your breathing cycle, and the elastance and recoil as the exhalation side, right? Your lungs are going back down into their original position. Oh, sorry. Okay, so the actual equations for these, compliance equals change in volume over change in pressure. Elastance equals change in pressure over change in volume. Um, if you're not math minded, which I personally am not math minded, that can be a confusing concept. Try not to let it throw you, just stick to the definitions. Normal value for compliance is zero point 0.2 liters per centimeter of water pressure. So all that means is that for every 1 unit of pressure, and for this, the unit is centimeter of water pressure, you get zero point 0.2 liters of lung volume for a normal person. For recoil, it's the opposite, right? As that pressure or as that volume is changing, that pressure is decreasing. And the normal for that is that 5 centimeters of water pressure per liter. These are not, I wouldn't put these on a flashcard. I'm actually going to say don't. The only part of this slide that I'm interested in you guys knowing or memorizing is just the compliance being change in volume over change in pressure, and then elastance being change in pressure over change in volume. And that triangle just means change in, it's a delta sign. So don't worry about the normal values. I will not be testing you on the normal values for this. I can't honestly think of very many scenarios where the normal values would come up in this way. So for this slide, just knowing the basic definitions of compliance and elastance, and then just the part that's in red. Um, don't worry about the normal values. I can't think of why you would need to memorize that. Okay, so for this one, we've got a little bit more of the lecture questions. When I say define the dynamic, define the static, define the lung compliance, this is an example of where I really want you to put it into your own words and how you understand it, so that you can really kind of lock it in, and I can see if this is something that you're understanding. Again, you can look at the due dates in the calendar. And for this one, there's 2 slides of questions. And that is it for that one.